Well, my name is Andrew Rawls. We'll kind of just introduce ourselves and kind of how we got into it, where we're from, and that sort of stuff. And you guys can ask some questions about, track, how do we do what we do, how do we get there, those sorts of things that you may be thinking of about if you're interested in doing it. What steps am I going to do to get there? So I grew up, I was born and raised in Cape. I went to St. Vincent's grade school, went to Notre Dame, did my undergraduate at SEMO in biology and biochemistry. Went to medical school at the Virginia College of Osteopathic Medicine, and then did my 3-year internal medicine residency in Joplin, Missouri, at the health system. And then I've been at St. Francis as a hospitalist for going on 9.5 years.
My name's Sarah. I was born and raised in Cape. I was Cape Central. I'm one of the nurse practitioners of the hospitalist team. My track was a little bit different, so I got my bachelor's in nursing, then worked as a nurse at St. Francis for about 8 years before I went back and got my master's in nursing and became a nurse practitioner for acute care patients, which means patients within the hospital. And I've been working with the hospitalist team for about 2.5 years now. I'm Tiffany Samples. I grew up in Delta, if you all have ventured south. It's near Youngstown. Graduated there, did my undergrad at SEMO as well in biology. Got my medical degree at AT Still in Cooksville, Missouri. And then did my internal medicine training in Tulsa, Oklahoma at Oklahoma State. And then I've been back at St. Francis for 6.5 years now.
My name is Trey Brotherton. I grew up here in Jackson. Graduated Jackson High School in 2004. Went to SEMO after that. Got my degree in biomedical science and minor in chemistry. Went to medical school in Kirksville by Truman. I did my residency up in Mizzou. Been working at St. Francis since about 2007.
I'm Geraldine. Let's see. So I did my undergrad at the University of Wisconsin in Madison, and then I did my medical school in Madison, Wisconsin as well, and then went to residency in Arkansas, a small town called Batesville in north central Arkansas, and then I ended up here. A year and a half, so I'm a newbie.
What questions do you guys have as far as the process of getting there, interest, what things you maybe need to be doing, may help you get into med school if that's what you're interested in? What can we answer for you?
Questions about what we do day-to-day, any of that stuff.
So let me get them this link. So bit.ly/ capital JHS and then lowercase club names right in the
Can you see it? Anyway.
dial in your questions.
Who out here, what do you guys want to do? Want to go to med school, nursing school, something different in the healthcare field?
Who wants to be medical school?
But nursing
What about radiology, CAT scans, MRIs, nuclear medicine, ultrasound?
Just say I thought you were ultrasound. Well, it's like, did we change you already?
There's lab school as well, where you get blood, urine, stool samples, and spinal fluid, things like that. And you run all the tests, we use a lot of that information to formulate what we do with our patients. So that's really vital role in the healthcare field.
All right, somebody post a question. Let's get you follow up. There we go. Who wants to answer now?
I think there's several best parts of my job. I enjoy the group I work with. We have a good sized group. This is a small sampling of us. There's like 25.
Total of 31.
Okay. Including our nurse practitioners and docs that are in our group. I also enjoy being in the hospital. You get a lot of quick turnaround. Patients come in, you get to see them, you your results in what you do. Hopefully they're getting better and then you're sending them home on their way. I spend at least a third of my time in the critical care unit in the hospital. So I would say that's sometimes the harder part of what I do. Some of those cases are difficult. There's a lot of difficult discussions to have with family members when things aren't going well, or when patients aren't doing well. Those are the sickest of the sick patients that we take care of. So I'd say that that's the hardest part.
Yeah, connect with that as far as the best is you see, for what we do, we see most of the patients that are coming in at the worst times. And it's really awesome to see once you put your skills to work and you get them to see them walk out of the hospital with their family. And you're like, okay, that makes me feel good, and I've done whatever you can do to get them home. The hard things are is no matter how good medicine is, you're always going to have those cases where it doesn't matter what you do. There's nothing you can do. And so I think that's kind of the hardest thing is having all that technology and all that resources that you have. There are times where you're just, there's nothing that I can do and I wish that I could do. And so I think for me, I think that's kind of the hardest part for me. But another best part is getting to work with these characters on a day-to-day basis. So that's for me.
For me, being a hospitalist, I love the 7 days on, 7 days off lifestyle. So you work hard, you get to play hard after that, you can travel on vacation. So we work half the days of the year. While we're working, we're pretty busy. It can be high stress at times. It's rewarding treating patients and being able to save lives. Like I was saying, the hard part is some people, they got under your care, and that's really tough to deal with that. And their families and their grieving families.
I think the best part is establishing relationships with patients. So you're on, like Trey said, for 7 days, and so within those 7 days, you can really develop strong connections. Different than primary care, but still really important. So they get to know you, you get to know them, and you get to know them through the process, which is nice too. I think the worst part is probably non-compliant patients. We all kind of can agree on that. It's really frustrating to see somebody come in over and over and over again for the same medical condition.
Such as?
Let's say a great example I had was somebody came in very uncontrolled diabetic who has a wound infection. So initially it's like a foot infection, they get it amputated, they don't take care of themselves, then it turns into a below the knee amputation, they don't take care of themselves, and it just kind of cycles. And they just don't do well.
Yeah, we see some frequent flyers with several diagnoses. We have some type 1 diabetics that we see on a regular basis, which is really heartbreaking, I would say, in the ICU because you're seeing people that are 35 years old dealing with medical issues that 70-year-olds should be dealing with. And so it's really sad to see that if they had controlled this diabetes, and there's a lot of different reasons that people don't, a lot of social issues and issues getting those medications, insulin's very expensive. We see some frequent flyers with congestive heart failure, not following food restrictions, that can be difficult. Smokers with COPD.
Drug users.
Yeah.
You said 7 on, 7 off. 7 on for how many hours per day?
We do 12-hour shifts. So we're all 12 hours. Like if you're rounding on the patients, 7 a.m. to 7 p.m. We don't always have to be in the hospital at full time, but you have to have your phone on the available.
Wow.
Yeah.
Do you always have a day or do you always have a night?
It depends on the schedule. It rotates. So we do a rounding shift, and it's like you said, 7 A to 7 P. We do an admission shift from 7 A to 7 P. All you do is get calls from the ER and admit patients that need to come to the hospital. We do a mid shift, which is from 2 p.m. to 2 a.m. To help. Our busiest time is usually late in the afternoon and early evening to help cover admissions there. And then we have a nighttime nocturnus, as they're called, that covers from 7P to 7A. And so there's always somebody there. So just depending on what type of lifestyle you want. Some people are night creatures, and we love those people. To take those nights. If we can.
That'd be great.
And so, being a hospitalist and what we do, there's multiple different avenues. That's just how we do it at St. Francis. Other places do it where you work an X amount of days. It doesn't matter how you do it. You work, sometimes contracted, you work 15, 20 days. You can work 2 days off 3, work 5. Doesn't matter as long as you get them. But in our group, the 7 on, 7 off, seems to work really well.
And that's for the docs. So nurse practitioners work a little differently. Yeah, we do it a little bit differently. We work 14 shifts per month. So it roughly averages out to 2 weeks a month. But we don't do our 7 days in a row all the time. When we're rounding, we do. So I start rounding tomorrow, all round from Wednesday until Tuesday. So I will do 7 in a row this week, but then my other 7 shifts will be scattered throughout the month. Which is a little bit different from you guys, but our shifts are a little bit different too. We have an admission shift, a mid shift, and night shift, but our hours vary a little bit. So the morning shift is 7 to 7, just like the doc, but our mid shift is 9 a.m. to 9 p.m., and then our night shift is 8 p.m. to 7 a.m.
Based on prior experience, what specialty path is recommended to those in the medical field that do not know what field they want to be in? So that question right there. So at St. Francis, you can actually get in and shadow. And so if you wanted to say, hey, I want to see what these hospitals guys are all about, you can actually sign up and you can actually shadow with us for a day or so. I've done that with some people in my neighborhood that have wanted to do get in the medical field. And the other different departments to get you a kind of sense of what they do on a daily basis. And say, well, that's not for me, or I like that. So there are opportunities at St. Francis for you guys to shadow and get a sense for what that is, especially if you're not sure. You have an idea, but you're not quite sure what it entails. We do have those opportunities for you guys to do that.
I think the biggest thing, do you mind if I add something real quick? I think the biggest thing is what I've seen is that people don't necessarily know what they want to get into, and then they go through medical school, and then they kind of pick a specialty, but they're not really sure if they want to do that, and then that causes a lot of burnout. And so make sure, like Andy said, you know kind of the basic premise of what you want to do, or shadow with that experience to make sure you want to do that. Because
like I say, I want to be an orthopedic surgeon. In my orthopedic surgery rotation as a medical student, figured out real quick that's not what I wanted to do. And so things have changed. So I think
I almost did general surgery. Yeah.
Almost every doctor changes at one point that I've talked to. Like, I wanted to be a surgeon when I was in medical school, and I'm not doing any more surgery at all.
Know that going into medical school, you do not have a path chosen. I think that prior to getting to medical school, you feel like that's something you probably need to know ahead of time, and it's not. I would say 80+% of people who think they know what they're going to do when they start medical school end up changing that. So the last years of medical school specifically is clinicals, and so you're going to spend your time one-on-one with docs, or if you're at a big teaching facility, if you were at Columbia, at Purdue, or like somewhere we trained, you're going to be with a whole team of docs. But you're going to rotate through all these different specialties and get significant exposure to them. Prior to committing to medical school, if you are not sure that that's the path that you want to do, I would definitely encourage you to reach out and do some shadowing, because there's a lot of different opportunities in the medical field. Just because we're doctors standing there doesn't mean that that's for everyone. So there's a lot of different things that bring us together and keep the hospital running.
Can I ask, and if this is personal, you don't have to answer that. What you said it didn't take you very long in your orthopedic surgeon rotation to know that, like a hospital, what was it about that? And then you said it didn't take you very long, like how long did it take? Like, we're done like days?
Yeah, so most of those rotations in medical school, third and fourth years, they're usually a month long. And so the couple things for me was I'm of the shorter stature. There are some manipulations and so forth that you can do as far as relocating hips and those sorts of things, but I would have had to use other mechanisms to try and do that. So I didn't like that I would have to use such as bed sheets and all these other things to try and help get the physics needed to get those back in place. Wasn't keen on that. The second part of that was the outpatient clinic. Seeing patients with chronic complaints, especially those that you're never going to fix, but are always going to keep coming back. That just wasn't for me. Being in the office and dealing with post-op complications and doing those sorts of things just was not my forte. So you get a pretty good sense real quick in those rotations about, hey, this is something that I don't want to do, and it piques your interest. For surgery, it was I couldn't stand there long enough to do that. Some of those surgeries are 2, 3, 4 hours long, depending on.
That's perfect case as a medical student, scrubbing at 8 a.m. and scrubbed out at 5 p.m.
So it's you learn really quickly during those rotations of, man, I really like that. Whether it's just what you're doing. Some people are like mechanics. They love to get in there and cut and fix and do that stuff. And those people, that mindset, they kind of lean more towards the surgery stuff. You'll find people that have the personalities where they're more hands-off. They like to use their brain. They like to talk. Those people usually tend to drift towards more of the internal medicine, family medicine, outpatient sort of specialties. And then every once in a while you get those that are, they like to be, what's it called, type A, that just love to be inside, non-social, and those sorts of things. Pathology usually is the path they usually take, or radiology, where they just sit in their office they have at home and read x-rays and do their thing. Don't ever get in front of patients, those sorts of things. So those things get
Those
sifted out
rotations
during.
really, I mean, the big things I always tell students we have when they're first coming in, we always get third year medical students, so we may have a person there first rotation. And my things that I tell them are, your big decisions are going to be, do you want to be in the operating room or do you not want to be in the operating room? Because that's going to divide you pretty quickly. And then you can decide, do you want to take care of kids or do you not want to take care of kids? And then that's going to help you really start to filter down the path. And then there's so many options that come off of like a general pediatrics or a general internal medicine. I mean, you have kidney doctors, you have diabetes doctors, you have 1,000 options, GI doctors, cardiologists, heart. So you have all of these options, and those come off of any of us that have specialized critical care, pulmonology, lung. So all of that comes off of a general start. So you don't also have to make that decision either. You can say, okay, I don't want to be in the OR. I want to do adults. Okay, that's the people standing in front of you. That's what we do. You get into internal medicine. What you do during those 3 years of training is spend time with all of those subspecialists that do endocrinology, that do cardiology. And so then you can see, does something pique your interest that you want to be more specialized than a general internist? Or do you enjoy kind of touching all parts of the patient and being involved in all areas, and then you would stay general? We all have the option. We could also practice outpatient medicine, and we would be like a general practitioner that we would see everything from. So.
Use this as a plug for my students. What they're talking about, the opportunity to shadow, I would love for every one of you to do that, because you learn, yes, this is what I like, and no, this is what I don't like. I had a student shadow, this was about 7 or 8 years ago. He's like, I want to be a urologist. I'm like, you sure? He's like, oh yeah, that's for sure what I want to do. And he shadowed a urologist for 1 day. 1 day. And in the first 2 hours, realized he had no desire to be a urologist after seeing actually what they do on a day in, day out basis. So like that is just as useful as finding what it is that you want to do, is eliminating those things that you don't. So do they go with you?
So you can just go on our website and just type in shadowing, and it takes you to, there's a whole online board you can go through. There is an age limit. You do have to be 16. However, we do have the Camp Stat program during the summers, and you just have to be in high school. That's the only requirement for that. And with Camp Stat, you guys are going to literally get to choose 2 places to shadow half days in, but then you'll be put into every area to somewhere along the time of the week. And then we can also work on setting up some specialized opportunities if you guys aren't 16 yet. And there's some other things you want to get into, we can work on that too. So, but yeah, our St. Francis website there, that you just pulled it up right there.
Type in shadowing. The first thing.
Yep.
Right there.
And you guys would do the shadowing experience then, because you're not actually going through a school at this point. So
It's an amazing opportunity.
Yeah.
By the way. Like my high school didn't have this. Take advantage of it.
It's
Because that's,
difficult to rank.
yeah.
Unless someone has a parent or a close family member that's a doctor or working in the field, it's very difficult to get to set up shadowing opportunities on your own.
and if you guys ever have trouble with it, then just reach out to me and I can help facilitate getting you into those.
And that way you know that that's what you want to do. Because if you start down that path of medicine, it's your goal. This isn't financially, it's
If you commit to
You can't-
medical
you commit to
school,
it.
you're committed to medical
You're
school. I
out.
wouldn't advise backing out at that
and
point.
so that is something that going into it, it's like, yes, this is what I want to do. I know that I'm going to take that dead on.
Student loan debt, approximately how much if you go to med school?
Mine was 140.
He's on the low end.
I'm on the low
That
end.
was about,
I think the average is
Yeah.
300,000.
I would say between 300,000 and 400,000 is what you can expect.
because you're interested in looking up while you're in medical school and while you're in residency, you're not paying that down. Luckily, there are opportunities where hospitals will pay student loan debt down, so for nursing and being a physician, so those are out there.
Also, do not let that dissuade
Yeah,
you
you know.
from going to school. It's a big number to look at on the front end if that's what you want to do with your life. We're all standing here and have done it, and I would do it again. I would take on that debt again.
And you'll be making money and able to pay that off.
For those of you interested in a field other than medical school, nursing school, PT, OT, radiology, just know that in all of those programs, you're going to get different clinical experiences. So in nursing school, you're going to do pediatric class and you're going to have a pediatric clinical. You're going to have OB and have an OB clinical. I very quickly learned that OB and pediatrics was not where I wanted to be. So when I graduated nursing school, those were jobs I could not even consider. But there's other fields. You'll get experience in home health and in hospice, in the office for primary care. That's in every field. Physical therapy, you're going to do clinicals in the hospital, you're going to do clinicals in an outpatient setting as well. So you'll be able to narrow down the area that you want to be in whatever field you decide to go into.
Similar to radiology, yes, I used a great radiology program. And so that's kind of the same thing you can shadow and see.
Chemistry, biology, anatomy, physiology, you can get into college classes while you're still in high school and get a jump on your bachelor's degree.
It's helpful.
AP classes, if you get those AP classes, even if it's like language arts or something, if you can knock that out in high school, it's helpful. If you did, knock that out in years.
Yeah, if there's, yeah, if you've got chemistry, physics, that offer college credit, absolutely take those while you're here, because that knocks off quite a bit of time that you spend in undergrad.
Anything
also
you can
cheaper.
do
And
to
it's
get
cheaper.
ahead in your credits, you're not gonna have to pay college fees for those classes in the future. So not only are you one step ahead towards graduation, but financially, those are classes you're not gonna have to pay as much money for.
Because
American too in college, I will tell you, it's a lot cheaper for you to take the classes here.
plus that gets you in med school faster, gets you out faster, at a younger age. So, which means more time to make money and save and pay off debt. So, yeah. Most medical schools are 4 years. There still is several programs out there that are combined 6-year program, with the first 2 years of the basic kind of college stuff, chemistry and all that stuff, and then add on 4-year medical stuff. So once UMKC is one, I believe Baylor down in Texas. I think there's a few more scattered around. Most of them are 4 years, but there is 6-year programs out there. So, how stressful is doctor's work? So you kind of learn, depending on what role you're doing. ICU is a little bit more stressful because you never know when that phone rings, what the nurse is going to say or what they're going to get. So during that 12-hour time period, it can be a little stressful. Rounding is kind of the same way, where you just don't know who is going to call or what their issues are going to be. But I think most of us do a fantastic job of once that 7 o'clock hour rings, it's done. We go home, we leave everything at work, and we pick it back up the next morning. So while you're at work, it can be a little stressful, depending on how your day is going and kind of what you see.
Yeah, I mean, winter is known for, cold and flu season, pneumonia season. We have more sick patients in the hospital then. That's more family discussions to be had, more sick patients to take care of. I think that's probably one of the beauties of what we do is that when I walk out of the hospital and my shift is over, I trust my partners who are there to take care of my patients while I'm not there. And at the end of my week, I can walk away, clean my hands of it, and I've got 7 days to recuperate from that. So I don't feel that I live an overly stressful life, even when I am at work. But it is nice to know, things that you don't think about are when you do clinic, which is not something any of us do. Your patients are messaging you constantly. They've got questions about their medications. They need refills. They need to get in and see you. They've got a cold, whatever's going on. So that inbox is always building up. I have a friend that's a primary care provider, and when we go on trips together, she has to keep up with that to some degree, even when she's out of town. And that's different everywhere you go. Every clinic is set up different. Some people have a nurse that helps offload some of that, or an assistant. But for us, pretty much when you walk out for the week, if you have signed everything you were supposed to sign, your box is pretty much going to be empty. You may have a couple of things in there when you come back, but you don't have a lot of extra work building up on you on your 7 days off. So we check our email, keep up with that. Occasionally we'll have a meeting or something for something we're involved in at the hospital. But we don't have a lot of work that has to be done on those 7 days off. So that's nice.
For me, day 6 is always tough because you know you're there and you have another day. And so it's like this balance of I'm not there yet, but I'm kind of exhausted and so for me at least.
You guys all ever had the same patient? Like, obviously, if you have shifts
Oh, yeah.
that follow, have you all had one patient?
Oh yeah.
Oh, yes.
Definitely.
Okay.
Some people are in the hospital for
Some
months.
people,
Oh,
yes.
goodness gracious.
or some
Yeah.
people are there every week.
Frequently.
Yeah.
And
They
so
come.
I take care of him this week, and she takes care of him next week, and he has him the next time they come in.
But you guys only take care of them if they're admitted, I guess, overnight?
Mhm.
Okay.
Yes.
Because technically you're admitted to the hospital even if you're visiting the emergency room, right? Don't you have to be discharged from that?
That's different.
Okay.
So if you are admitted to the hospital, like truly admitted to the hospital, you would be seeing one of us, or maybe you came in under one of the surgical services. Even a lot of those patients we're involved with, just because the population is older, a lot of them have a lot of medical things like diabetes, high blood pressure, that we're going to help manage. But to be admitted, you're coming in, you're staying maybe 1, 2, 3, however many nights in the hospital for your problem.
Okay, so for like cardiac ICU, for example, they're obviously going to have a hospitalist who is also a cardiologist. Yes. No?
So they would have depending on what they're there for. So let's say that someone comes in for a heart attack, and it's like they're the kind of heart attack that hits the door and they need to be in there getting a stent put in their heart within an hour and a So they're going to be admitted to the cardiology service because they're going to go from the ER straight for intervention with one of the cardiologists. And then depending on where they get that stent at, most of those are going to spend a night in our ICU. Sometimes the cardiologist will just manage those patients by themselves. But we have a hospitalist that works in the ICU as well as a pulmonary critical care doctor. And so if they have other medical problems, diabetes, thyroid trouble, the cardiologist can manage high blood pressure. That's kind of in their purview. But if they've got a lot of other stuff going on, they may get us involved to help with that. And we'll help adjust those medications, make sure we really maximize what we can do for that patient in their time in the hospital.
We got a weird question. What's the most medications you've ever seen that somebody's had? Like, you had to manage, they came in and they're taking.
I would say 30 to 40. Yeah.
Be thankful for your youth, children.
Yeah.
Yes, 30 to 40, and you have to think about how does this drug interact with this drug, and these drugs interact with that drug.
Well, I mean, that's some of the problems that we run into actually is that there are people out there prescribing these medications not thinking about those interactions. I had a patient about 6 months ago. The ER doctor called me. Hey, this patient is really just not waking up. I don't really know what's wrong with her. She's not like comatose, but she's not with it either. I walk in the room, and ER doctors are very good for emergencies. When you start talking about all this in-depth history taking, medication questions, that's not where they thrive. That's okay. Everyone has what they do well. And so I go in, I start talking to the family, and they're like, well, 2 days ago, she went to her pain doctor in St. Louis. And I'm like, well, there's a red flag. Why are we going from down here all the way to St. Louis to see a pain doctor? So that's kind of odd, right? Like, we have a lot of pain doctors here in town. Why would she be driving 2 hours to see one?
Because that suggests
that she has a narcotic abuse problem.
Gotcha.
And so I said, okay. And they were like, well, he started her on 2 new medications. And I'm like, really? 2 new medications? Now, this patient is on dialysis for her kidneys. So every medication that you give someone, it has to be cleared out of their system somehow, right? That's usually either through your liver or through your kidneys. Any patient on dialysis, you have to look at every medicine you give them very closely. I said, do you know what medicine's there? Oh, yeah, we've got the bottles right here. Now, they've got a backpack full of bottles, okay? So they pull out the 2 new bottles. Neither of these medications should a dialysis patient ever have been put on at all. And I was like, well, here's the problem. This is why she's asleep. It'll clear from her system eventually. We may be asleep for 3 or 4 days. I'm not sure. So we're just going to tuck her in the ICU and keep a close eye on her. She woke up, but it was 3 or 4 days later.
What were the meds? Not that we would know.
One's a muscle relaxant called baclofen, and one was a pain medication called Ultram, which is not great. So baclofen was the big problem. But the fact that we prescribed both of them at an appointment together to a patient they should have never been given to. So that's a lot of what we do is seeing side effects of medications or inappropriate dosing of medications.
And I think that's one of the frustrating things that we all agree, like working with the ER, it's good and bad, but like working with the ER and an admissions team. So what happens is patients come in and then the ER decides this is an admit or this is not an admit. And then our job as an admissions service is, hey ER, no, this can go home, no, this needs to stay. And so we have to kind of communicate and use our medical knowledge to be like, hey, try and convince them and kind of build a case for why they should be admitted or not. So it's kind of, I don't know, kind of like a
actually kind of built into 2 questions there.
Oh,
What
there
made
you
you choose this career path, and what made you land on becoming a hospitalist? So, career path, medicine was, I just like the science, I like the anatomy, I just like being around people, and so you put it all together, medicine seemed to work. And using critical thinking skills. So that's something that you use day in and day out, all day long. Love every minute of that. And so being a hospitalist, an internist, and internal medicine doctor kind of fits all of that. And so I love when the ER calls with an admit because you get to be like Sherlock Holmes. Like it's game on. Let's go talk to these people, patients, and let's see what's going on, and we're going to figure out what's going on. A lot of times it's basic stuff that you learn about, bread and butter stuff, pneumonias, heart failures, and all those things. But every once in a while, you get that phone call that you're like, ah. And we always say on our team is, if you pique our interest, that's not good.
Yeah, we're sorry for you. It's not good for the patient to be the interesting patient.
Yes, because when you're interesting to us, that means something really cool to us is going on. Maybe not so good for the patients. A lot of times it's treatable, but for us, it's things you don't see a lot. And so I've had several of those cases, but that's kind of being a hospitalist. That's you get the first crack of those patients that are sick. You get to really use your critical thinking skills, and you get to really come up with the diagnosis. And then when your rounding partners pick them up the next day, you pretty well get everything on board. And if you've done your job right, you're going to make their job easier moving forward.
You piqued my interest with that. You said you learned like some rare cases and some weird stuff. Like,
Yeah.
What sticks out to you?
One was leprosy
In Southeast Missouri?
in Southwest Missouri.
Oh, wow.
That was in.
Did this person travel to someplace?
So they were a migrant from I forget exactly where, and it was I always remember where I was that night and what time it was and all that when I got the phone call or the ER doc saying, hey, you need to come take a look at this because I don't know what this is. You go down there and I'm like, this is what you see on, like this is the zebra, like you get on a board kind of test picture of what is this. I'm like, this is leprosy. And,
How do you treat
well, that's a good question.
it's bacteria, right? Or no?
That takes a lot of training.
Oh, really?
Yeah.
There's a medication.
It's
But I mean, at that point, a lot of the flesh is kind of rotted off.
Yeah, it wasn't so successful. We ended up transferring that patient to Higbee.
Okay.
So
Yeah. Some of the stuff we ended up doing.
yeah, that was called to the State Department, State Health Department. You get to report that, and then they ended up getting transferred to University of Kansas.
How like contagious is that?
It's not highly contagious.
Okay.
Immunocompromised people, but that was one of them. Pheochromocytoma, mass on the adrenal glands producing excess hormones. You don't see that very often. Two of those in residency.
We had a rabies.
Really?
Oh, we did have a botulism. Yeah.
Other than Botox botulism?
Yeah, and adult botulism, which is highly unusual.
And there's a lot of botulism toxins in Southeast
Yeah. Yeah.
They're just not directly from the bacteria.
That's right.
No, this person was in the ICU.
So yeah, so that was for me.
I would say that, mine was similar. I was interested in the sciences. I knew that. Interested in medicine. The reward of getting to help people. And then,
We're more objective thinkers, I would say. Like we like math and science. I wasn't. If you told me to write a story in high school, I hated that. I didn't want to use my imagination. I'm not creative. I like 2 + 2 = 4. So I like to memorize a lot of information and regurgitate that. That's what you have to do. But that's cool. We don't write
but
a lot
that's
of
not
stories.
everyone.
Yeah.
There were definitely some people that came from different backgrounds. So,
I would say that's the majority.
but that is definitely the majority. Yeah.
Like A-type personalities, stuff like that.
I think as a new doctor, to add to that, it's like finding out the limitations of your system. So like a good point is like we don't have technology, and so like telling the ER, hey, we probably shouldn't admit this needs to go to St. Louis, like the leprosy case that you had. So kind of balancing that is kind of interesting, but also super important because you don't want to admit somebody, and then you guys rounding like, what are you doing? You know, as a new doctor, it's kind of like it's frustrating. You guys are experts, but from that point of view, limitations are important.
Common diseases of illness.
Diabetes.
Diabetes around here, big. Metabolic syndrome, obesity, big one. COPD from smokers, blood pressure, cholesterol,
Heart failure.
heart failure,
And heart disease.
Stroke.
and heart disease.
In that sequence, did you just name 80% of what you see?
At least.
Oh, wow. Okay.
Yeah, most of the patients that we admit are heart failure, who are diabetics, uncontrolled blood pressure, throw in some drug use causing their heart failure. I mean, like methamphetamines and those sorts of things. Cocaine, pneumonia.
So methamphetamine, this is a dumb question, I'm sure, contributes to, because I'm picturing heart failure, I'm picturing somebody who's 75, 80 years old with a big old floppy heart from just years
From
of
ischemia. It's a toxin to the heart muscle, is what methamphetamine does. And so it will also cause your heart to get very large and floppy. Cocaine affects the blood vessels because it's a vasoconstrictor. So it's similar to ischemia-induced cardiomyopathy
Oh, wow.
in that it clamps down those blood vessels and puts you into heart failure.
I see a lot of diabetics that
Uh,
uncontrolled diabetes with A1C of 11.
Strokes, UTIs in the elderly are at the daily 1 or 2 admins. GI.
So they get admitted for a UTI?
Yeah, most of the time it's because they're septic or vital signs aren't stable.
Oh, wow.
Or their labs are really out of whack, or they're just completely confused and.
Older people often don't recognize the symptoms early on, and so they're going to come in sicker. They're not going to have your typical like
It
burning.
hurts when I pee,
Yeah.
or
Yes.
something's wrong, and go to community care, and
Yes.
cranberry juice.
Yes.
Gotcha.
So it's a little later presentation, and they're usually sicker when we get them. They also have less reserve in general. If you're 80 years old, you're not going to bounce back from something as easily as a 20-year-old. So.
I think specifically nursing offices. Because they don't.
Yeah, most of our patients are chronically ill patients with an acute illness. And so every once in a while you do get the young patients that have a kidney stone or need to have a surgery or ask to see them for the surgeon. For the most part, 50 and over is about what we take care of. So.
I would say I get some of the younger in the ICU with the type 1 diabetics,
Drugs.
the drugs. Occasionally we'll get a meningitis case, things like that. We'll bring in any other person, but for the most part, we've seen a few really bad young cases from vaping and from puffing of spray paint.
So what happens with the
It can cause a really bad reaction in the lungs. And even people who aren't asthmatic or anything else, it basically causes an acute lung injury. And so they end up on a ventilator, so they keep down their throat on life support. And it's just a matter of, are their lungs going to recover or not? There's not a lot that we do to treat that. It's supportive care, but it can cause a really severe acute lung injury.
what's happening in the lung?
Tons of inflammation.
Okay.
So everything has just become very inflamed. And that leads to some degree of fluid being in there. It's a little different than saying like congestive heart failure fluid. It's an inflammatory fluid, but basically they can't breathe through it. So we have to put them on support and try to manage that.
So don't vape.
Yes. Listen, James. Of course, this is probably not the crowd.
Yeah.
Yeah.
We had a girl that was having black spray paint. That was the year I started at St. Francis, and she was so sick that we couldn't even, usually if you're on the ventilator for about 2 weeks, then you're going to get a trach if you're not ready to come off the ventilator. That's just kind of the standard of how things are done. But she was so sick that we couldn't do that. When she finally got well enough, about a month into her stay at the hospital, for that to happen, when they did that and we pulled the tube out, the entire tube was just black from the paint that was coming out of her lungs. And they had gone down multiple times trying to suck that out and clean it out, but it was terrible. Any other questions? Any questions?
On the practitioner side, is yours very similar to what they do?
Yeah, so I have a collaborating physician, so they work independently, I don't work independently. I can see my patients on my own and come up with a plan of care, but they kind of watch over what I'm doing and either agree or give me tips on what I need to do. I think for the most part, I do listen on my own, but if I have a question, it's, hey, can you look at this or what do you think about it?
Now, a nurse practitioner, like a general practice, can prescribe and things like that.
Yes, so I can prescribe medications. I cannot prescribe controlled substances or narcotics. You have to have a special license to do that. And you can do more certifications to get that. I have chosen not to do that. But yeah, I do antibiotics, blood pressure medicine, insulin, any of the medications that anybody's ever heard of other than narcotics and controlled substances.
And none of our nurse practitioners do controlled substances. I mean, we're not a trained clinic, we don't write a lot of controlled substances going into the hospital anyway, and it's just really not necessary that they do an extra certification for that.
But you do have some kind of like some kind of pain drip, or no? Like, or is there any kind of like IV thing that you do?
She can write those things in the hospital, just not going.
Sure. Okay, but I'm saying like, how do you? I guess this is for all of you guys. How do you handle that if a patient is talking about pain?
Are you saying like how do we delineate between real pain and not real pain?
Aha!
Yeah.
Yes.
Okay. It's difficult.
Yeah.
You get repeat offenders, patients that come in complaining of the same thing, and there's no evidence that those things are really there.
You have to have objective evidence that, like if you have a CAT scan finding where your appendix is ruptured, then I can say, oh, you have pain from this, I'm gonna give you some IV oil. You know, so if I can find objective evidence, you know, to back up my, you give me an IV pain medication. That's a big thing for me, how I decide.
Yeah, and I think we practice pretty similarly within our group, and that would be, we see a ton of patients on chronic pain medications, right? Unless you come in overly sleepy from those medications or having a side effect from them, or having a reason we can't continue them, we're typically going to continue someone's chronic pain medication. They're seeing someone for that, it's really not my place to delve into that. As far as people who come in demanding IV pain medications, you're going to need to have something going on, right? You don't take IV pain medications at home for your chronic pain, and so that's not a reason for me to write them for you just because you're in the hospital. And that's how I practice, is that if you have something new going on that causes pain, then absolutely we're going to get you something stronger for that and get that treated and managed. But if the nurse calls and says, hey, the patient in room 3501 is complaining of, pain, well, first question, where's the pain? Well, it's their back pain. Okay, well, they can take their home medication that I've written for that, but we're not going to do IV medicine just because we're in the hospital, because that's creating a problem. There's more, you get a really rapid onset with IV pain medications, and they're highly addictive, so they really need to be reserved for having an acute problem going on.
I think for me, nursing staff really, they spend a ton more time than we do with patients. And so what I usually do is I say, hey, what do you think? Is this like real pain or is this fake pain? And they have a really good understanding because they've been with them for so long. And so I kind of trust them or rely on them, and because they're very open and they've been through this.
And the patient's vital signs.
Yeah,
That's true.
There's
That's true.
indicators, is their heart rate up, is their blood pressure up, are they breathing through, are they sleeping, and then as soon as you wake them up, oh, I have 10% pain. Probably, well, it wasn't bad enough to keep you awake from sleep. Assessing your patient and knowing your patient is part of that.
It's hard to fake tachycardia.
Right, yeah, I mean, there's a reason for tachycardia, yes.
What other questions?
Did you answer the one about stress? How stressful you work like this? Okay.
Someone was told me that hospitalists are very overlooked, underappreciated, something like that.
I think you just don't see us outside of the hospital, so we don't have necessarily an ongoing relationship with patients once they're out of the hospital. So unless you're in there seeing us, sometimes you're only there for one night, so you see us
wants to go home.
I think you're to the point of, like, oh, there's a cardiologist, they do that.
Yeah,
There's a
probably.
hospitalist. And so, I think the hospital can recognize that we do about 90% of every patient that comes through there. We make sure that you get the care that you need. You need to see a heart specialist, absolutely. We're going to call them and get them involved in those sorts of things. We don't necessarily sometimes get, oh, the cardiologist came in, put a stent in, I was good to go. Yeah, okay, they did the work, but we were the ones that, hey, we kind of caught that when you kind of missed it over here, and so that's where, and we don't really care
That's okay.
whatsoever
Yeah.
that we don't get praise or through the hospital does enough for us as far as for the care that we provide our patients and those sorts of things. So we show it in the quality of work that we do and getting the patients home safe and better, not coming back to the hospital. That's the big thing. So we know, even though we may not be getting that outside, hey, you guys did a great job, sort of thing. It doesn't. We know we did a good job.
I also think that a lot of our colleagues, as far as other specialists, recognize our contribution to patient care. I mean, I have surgeons and other docs pick up the phone and call me and say, hey, I just got this patient I need to run past you. I'm just not sure what's going on here. I'd like to pick your brain about it. And I think that speaks a lot to the respect that they have for what we do and what we offer the patients, is that they do call us and ask us for help. So that says a lot that they respect our professional opinion. And again, yeah, I mean, we're never going to be the quarterback, right? I mean, I always say when I introduce myself to patients, I'm actually the captain of your ship while you're here in the hospital. So my job is to make sure that you see everyone you're supposed to see and that we cross every T and dot every I before you go home. So you're going to see a lot of people come in this room, and if they tell you something that doesn't make sense, I'm the person that you can ask because I'm the one that's going to talk to every one of them every day and make sure we have a cohesive plan. Because sometimes you've got a cardiologist, you've got a general surgeon, you've got a nephrologist, and everyone thinks they have a plan for their one special area they're working on, and somebody's got to put that whole picture together, which is what we do. So.
You guys treat the person. I think the specialists treat the organ.
Yes.
Yeah.
That is a good one.
You know a little about a lot, you know a lot about a little.
Right. Yeah.
There's like a show or like a movie like you guys thought was like the most realistic, like relating to like hospitalists or any doctors. What show would that be?
The Resident.
Yeah.
Resident.
Yeah. Not Grey's Anatomy.
Not Grey's Anatomy. The Resident.
I think Stripes is also pretty good.
I heard somebody said Scrubs. Never watched it.
But in the recent
Yeah, the
time
Resident.
frame,
Yeah.
The Resident is pretty.
And what just came out because Jenny was saying there's a new show. It's like 3 episodes in, and Jenny said it's pretty accurate.
St. Dennis Hospital.
Yeah. I haven't seen it, but one of our nurse practitioners.
You know my,
Yeah,
you know
I
our,
know it.
so do you know our dad, Christopher Crocker?
Yeah.
Oh, he's so cool.
I'm not gonna lie. Whatever you say about him, we're not gonna tell him.
Okay.
You have to sweet talk a lot of patients doing stuff, or you can talk to their families a lot more. Like, you don't need someone to take prescription medicine or something like that. You talk to them, or you talk to their families.
Both. Yeah, pretty much. If you've got a patient that's kind of being hard-headed and those sorts of things, you kind of spin it as, well, if you don't take this, this is what's going to happen. A, B, C, D. If that's what you want to have happen, feel free not to. But if you want to get better and not come back and see me, because my goal is to, I get you out and you never see me. That's the whole. You come in for that one thing or 2 things, we get you out and you never come back. And so we do a lot of education on those meds and on your disease process as to why you need to take care of it, because if not, these things are gonna happen. So it goes both ways. Most of the time, it's really good. Like when you have the old guys in there, the best person that can be sitting in that chair is his wife or their daughter, because anything he says, you're gonna look at there and they're gonna say nope, or they're gonna say something completely different. And so it's always nice to have other people in the room with them, because they can.
It's also just good to have a second.
Yeah.
people miss a lot of information. There's a lot of people coming in those rooms, going over stuff with them, and so it's always good to have another person in there with them. But yeah, I mean, ultimately the patient has to agree to take it, no matter who you tell. So unless they have some sort of developmental delay or reason that they can't really comprehend that, you really have to get the patient on board with what you're doing.
And I think that it brings up another point of like whether somebody's actually competent to make medical decisions. So we get a lot of patients that they're like, oh, I don't know if they're gonna be able to understand, and
They're just
so
not competent to make their own decisions, and that's when we have to bring in
right.
family, you know, do they have a guardian or power of attorney to make decisions for them? And on that note, a lot of times we have to respect the patient's decision to make a bad decision. I mean, sometimes they don't want to have a life-saving surgery, and they understand what that means, and we have to respect that decision.
Even if they're family.
Yes.
Until more than one person. But, well, the nursing staff frequently have a hard time with that because they are the one in there assessing, can the patient make this decision? Do they understand it? People are allowed to make their own choices. They do it every single day outside the hospital, and it's not my place to put a limitation on their decision making inside the hospital. So our job is to give them the options available to them and make sure they understand the risk and benefits of any of those options. And if they do understand those risks and benefits, then they can make whatever decision they choose. So I'm not going to make those choices for them.
Thank you guys very much for being here. Is there any other questions before we close up shop for a minute?
Thank you guys for all the questions. You really got it rolling this time.
Who's taking your guys' place right now since all you guys are in the classroom?
So he goes to work shortly, right after this. He's on his off week. She's getting ready to start. She's on her off week. And I'm on my off week.
You guys dressed out on your off week.
Yeah.
You're enjoying your off
the
week.
role.
It's convenient for me.
But benefit of working in a hospital, you get to wear comfy scrubs all the time.
Well, I hope this was helpful.
Yes, quite so.
If medicine, some sort of field, doesn't matter what it is, go and chat. Go and see what it's like, and then make your decision from there. And so I don't regret my decision whatsoever. I have fun going to work.
There's a lot of grouchy people out there that are going to tell you, don't go to medical school, don't do that. Don't.
You're going to have a job.
Yeah.
There's going to be a provider shortage moving
Across
forward,
the field.
and so getting a job and where you want to live and all those things, not going to be a problem.
There's always going to be sick people.
Yep.
Oh.
I always
Because
say
people
we
have
have
the
to.
ability to make choices.
That's
And a
right.
lot of the choices are bad.
Yeah.
Therefore, there's job security.
There's a lot of job security in this area.
I always say, we have the job that if people would just listen to us, we would put ourselves out of business.
Yeah.
But
They don't.
they don't.
Here we are.
And as far as the transplant, one of the biggest things is coworkers. They're the most important thing. Making sure you have a good work life and enjoy talking with your coworkers. It makes it so much easier.
You guys seem like there's good chemistry between your teams. Like just watching you guys interact. That would make me want to work a place to if I you know what I'm saying. So that's a big, especially with what you guys do. As one's got to take over for another one, you have to be in agreement on how things are done.
So what's interesting about our group is 80% of them, maybe even higher than that, are from this area. We went to school together. We knew each other in high school. We knew I knew about 4 or 5 other partners in high school, and so we.
And there's a lot of us, 5 or 6 currently, who came through here as medical students and rotated with this group and chose to come back to the higher medicine group. So, yeah, Trey and I both and several other partners.
I can tell you as a director of a different service line, I always tell Crystal I'm jealous of her group. I wish my groups would be like that. So they're always getting involved in all the hospital activities, Thanksgiving boxes.
We're a little competitive.
Yes.
We like to win.
A little, I think you guys are a lot competitive. So they're a wonderful group.
Thank you.
Yeah.
think I will see you again until next year. I worked out some dates with Chloe for next semester, so